Hello everyone, my name is Junyi Gao from Peking University and IQVIA. I'm glad to introduce our work on disease progression modeling, StageNet, stage-aware neural networks for health risk prediction. This research is carried out by Peking University, IQVIA, Peking University Third Hospital, Temple University, University of Illinois Urbana-Champaign, and Georgia Institute of Technology. This oral presentation consists of 4 parts: clinical background, challenges, method, and experimental results. First, we will introduce the clinical background of our work by answering 3 questions. The first question is, what is EHR data? Nowadays, electronic healthcare information systems are widely used in various healthcare institutions, which can record the lab test results and health information of patients in terms of electronic health records. EHR can be seen as a type of high-dimensional sequence data and provide essential healthcare information for the data-driven healthcare prediction. Among all healthcare prediction tasks, risk prediction is an important one. So, why do we need to evaluate the health status of patients? Actually, health risk prediction is of great interest to physicians. By predicting patients' health status, physicians can make personalized treatment plans or take action to prevent adverse outcomes. The precise risk prediction requires a high level of clinical expertise and experience. However, these medical resources are extremely limited, especially in today. We are online today is because of COVID-19 pandemic. Here are some statistics for COVID virus. There are about 20% patients in severe condition. The overall mortality rate of COVID is among 0.7% to 4%. However, the mortality rate for patients with severe condition is about 50%. In the US, it is estimated that the bed shortage is about 17%, but the ICU bed shortage is over 47%. If we can use AI-based risk prediction models to help physicians to identify patients at severe condition or high risk, we can better allocate limited medical resources and further reduce mortality rate. The second question is, what is disease stage and why it matters? In our context, the disease stage refers to a time period with consistent status progression. It is not specific to a single disease, for example, Alzheimer's stage 1 or 2, but considers generally all comorbidities a patient has. We use the variation of albumin and hypersensitive C-reactive protein of an end-stage renal disease patient as an example. We can observe that the patient's health status between T1 and T2 is different from the rest time period. The sudden decline of albumin and fluctuation of hCRP indicates the patient's status is deteriorating rapidly. So, we consider the patient's health condition enters a new stage at T1 and recover at T2. So, how disease information can help us predict patients' risk? According to recent research, some COVID patients will suffer severe symptoms and their condition will dramatically deteriorate in a short period of time. For example, in the figure, patient status can be divided into 2 stages. Before day 12 is a normal stage. However, after day 13, patient status rapidly deteriorated and various complications occurred. This period is obviously a new progression stage. If we can detect them in time, we can take actions to prevent adverse outcomes. However, using disease progression stages for risk prediction is not straightforward. We still face 2 major challenges. The first challenge is how to extract disease progression stages from complex EHR data. Although disease stage information is important, they are often unavailable in data and sometimes not even clearly defined for many diseases. Previous disease progression modeling work implicitly assume that disease progression is smooth in time by controlling the forget rate of LSTM. So the longer the time is, the greater the change of health status will be. However, in reality, disease progression speed can vary significantly depending on the underlying disease stage. We need to explicitly modeling the underlying stage and detecting change points in patients' disease progression. The second challenge is how to leverage disease progression stage information for more accurate risk prediction. Recent clinical research indicates that disease progression has different patterns, and they are highly related to patients' health risk. Intuitively, disease progression patterns should be similar within one stage, but different across stages. For example, the progression pattern in stage 2 is obviously different from the other stages. So, our model should learn to extract and select informative patterns from each disease stage for more accurate risk prediction. By jointly considering the above research challenges in clinical practice, we propose the StageNet. StageNet comprises two modules, a stage-aware LSTM module and a stage-adaptive convolutional model. First, at the t time step, the stage-aware LSTM takes current visit Vt and time interval delta t as input to calculate current hidden state Ht and current state variation St. Then, the hidden states in the observation window K will be fed into the stage-adaptive convolutional model. The convolutional model will extract progression patterns at the current stage and recalibrate this pattern using the progression theme Zt. Finally, the module will use the recalibrated pattern to predict health risk Yt. Our goal is to infer the state variation of the patient's health status while constructing current health status. Original LSTM used current hidden state Ht and cell state Ct to store memories. If we can differentiate recent and old history in Ct, we can determine whether the change to Ct is due to old history or recent history. Then, a change mainly due to the recent history means the underlying disease stage has just changed. Following the order neuron mechanism, we use two new gates as masks to store historical and latest information respectively in Ct. The first gate is a master forget gate, which controls old history, and the second gate is a master input gate, controls recent history. The two gates are computed as the following equation. Note that the Vt represents input features from current visit. Delta t represents the time intervals between two visits, and Cm represents cumulative sum. The arrow above Cm indicates the direction of cumulative sum. For example, following the properties of the Cm operation, the values in f tilde t are monotonically increasing from 0 to 1, and those in I tilde t are monotonically decreasing from 1 to 0. Hence, f tilde t and I tilde t can be used to serve as a softmax for storing historical and latest information respectively. By using time intervals between visits and current visit conditions, our model can jointly consider the impact of time and physical conditions on disease progression. The general idea of order neurons is to divide neurons into high-ranking and low-ranking two parts. We store latest information, that is CT, in the high-ranking part, and historical information, that is CT-1, into low-ranking part. Concretely, we update cell state CT as following equations. Values in f tilde t are used to decide which dimensions in CT to store long-term information about status progression, and values in I tilde t decide which dimensions to store short-term information, which is CT. However, the short-term CT and long-term information CT-1 may be overlapping, so we use WT as a mask to store the overlapping information. Besides the overlapping information, the non-overlapping part information in CT-1 and CT are stored into CT respectively by reducing the overlapping mask. We use a toy example to better illustrate the equations. We assume the dimension in CT is 5, and the pi tilde and pf tilde is this. Then we can calculate I tilde t and f tilde t following the equations. Wt is f tilde t multiplied I tilde t. Then we can obtain the two masks for historical and latest information. So there are 5 neurons in CT. According to the mask, the first 2 neurons stores the latest information, which is CT caret, and the last neuron stores historical information, which is CT-1. The middle 2 neurons stores the overlapping information. However, because we use softmax activation, the actual values in f tilde t and I tilde t are decimals instead of 0 and 1. The stage variation can be evaluated as this equation. The value of St decides how much history information is used to calculate the current CT. In our toy example, the St is 2. If St is large, there is almost no historical state information in current cell state, which means the patient's current health status have changed a lot compared to historical status. In other words, a large St may indicate the patient's status have entered a new stage. To leverage the stage information learned from the LSTM, we develop a stage adaptive convolutional model on top of the recurrent layer to extract and recalibrate patient health progression pattern for risk prediction. We expect StageNet can extract patterns that are closely related to patient current stage using convolutional filters. We also design the model to adaptively select the most informative patterns for risk prediction at the current stage. The first step is learning stage progression patterns. We extract the progression patterns of current stage by using stage-weighted convolutional operators. We modify the original CNN by integrating disease stage information into the convolution operation. At t time step, we calculate the distance between stages of historical visit within the observation window and the stage of current visit as this equation. The values in delta St are monotonically decreasing from 1 to 0. A distant hidden state will have a larger distance to current hidden state. Then, we use the distance to reweight the hidden state and feed them into a CNN layer to obtain raw progression patterns UT. Then we need to extract progression theme at current stage. The importance of these patterns may vary and depends on patient status on different stages. In order to select the most informative patterns at current stage, we should provide the model with a global view of patient status at current stage. ZT is the weighted average of hidden states within the observation window, and it can be regarded as the progression theme of the current stage. The importance of different temporal patterns will be calculated based on this theme. The last step is to recalibrate progression patterns. After obtaining the status progression theme at current stage, we first calculate pattern importance using the global status progression theme. Then, we calibrate the raw patterns using the importance weights. This step is trained to model the importance of different patterns and selectively give more weights to the representative and predictive patterns, but suppress the unimportant ones. Finally, we use calibrated patterns and hidden states to predict current health risk. The final part is the experiment. We conduct 2 experiments, a health risk prediction and a patient subtyping experiment. For the risk prediction experiment, we conduct the decomposition prediction experiment on the mimic dataset and the mortality prediction on the ESRD dataset. StageNet outperforms all baseline models across both datasets in all evaluation metrics. StageNet achieves 10% higher AOPRC on mimic dataset and 12 higher AOPRC on the ESRD dataset compared to the best baseline model. In order to understand how different clinical events affect disease progression, we further analyze the health status stability of patients with different causes of death in the ESRD dataset. We compute the average stage variation for each patient. A patient with stable health status will have a low ST. The result shows that the patient who died of peritonitis, CVD, and CVE have the highest ST. These diseases are acute diseases and have high mortality rates. The health status of patients who have this disease tends to deteriorate rapidly in a short period of time, which explains why our model believes these patients' status are highly unstable. In contrast, patients with cancer have the most stable status compared to other patients, since their health status often deteriorates more chronically and have longer survival time. The stability of patients' health status is an important indicator to evaluate patients' health risk. We also divide patients' visits into 3 groups according to the predicted risk. Then, we compute the average stage variation of each group. The results show that the health status of patients with high risk is more unstable, and patients with low risk have the most stable status. We also conduct patient subtyping experiment on the ESRD dataset to investigate the expressive power of the patient's representation learned from the StageNet. ESRD is a chronic disease, and patients need to receive continuous medical treatment for years or even decades. We report the clustering Kalinske-Herabath score and the average ground truth mortality risk in each cluster. The results show StageNet achieves over 58% higher Kalinske-Herabath score compared to the best baseline model. The average risk in each cluster shows that StageNet divides patients into 2 high-risk groups, cluster 3 and 4, and 2 low-risk groups, cluster 1 and 2. In order to interpret the clustering results in terms of subtyping, we compared the medium-risk and high-risk clusters with low-risk clusters using t-test to identify discriminative features. We found that there are 5 to 7 significant features in each cluster, and we reported the top 5 significant features ranked by p-value in the table. Significant features in different high-risk and medium-risk clusters are almost the same for all baseline models, which indicates that these models are unable to further distinguish subtypes among high-risk patients. However, StageNet can identify more discriminative features. The features in cluster 3 are important indicators related to patients' nutritional status. These biomarkers can reflect patients' health status from a long-term perspective, while in cluster 4, these features are mostly related to acute conditions, such as heart failure or infection. You can find more analysis about clustering results in our paper. In order to intuitively show the implication and prediction process, we developed a visualization system. The horizontal axis denotes the visiting time, and the vertical axis denotes the prediction results of health risk. The red line indicates the predicted risk, and the blue line indicates the stage variation. As you can see, this patient visited the hospital from 2008 to 2012. For the case patient, there is a distinct rising period of risk since 2009. This means the model raises alarm that the patient is suffering from a high health risk, and unfortunately, the patient dies 3 years later. We can also notice that there are 2 stage variation peaks at 2009 and 2012. What happened? We clicked the corresponding key features. The values can be shown in the figure. So, at 2009, the creatinine and urea have a sudden rise, and this leads to a large stage variation. If we reduce the value of these biomarkers, you can see the stage variation also reduced. But at 2012, a lot of biomarkers of the patient are rising abnormally, which means the condition of the patient may deteriorate rapidly. So, this leads to another peak of stage variation and high mortality risk. There is another example of ESRD patients. This patient's health risk is low and this patient is still alive. But we notice that there is also a stage variation peak at 2009. As you can see, the patient's hsCRP and white blood cell have a sudden rise at this time point. This may be because of an infection. If we reduce the values of this feature, you can see the stage variation also drops. Albumin is an important feature for ESRD patients. Higher albumin may indicate the patient is more healthy. So, if we reduce the value of albumin, you can see both stage variation and mortality risk rises rapidly. We hope this online system can help doctors put an eye on patients' risk and stage variation and take in-time treatment to patients to prevent or delay the adverse outcomes. Thank you for your listening. Welcome to scan the QR code to try the visualization prototype system and see the case patient. Thank you.